Hi, I'm Dr. Peter Szilagyi.
And I'm Dr. Alex Fiks.
We will discuss a bundled practice-based intervention to increase HPV vaccination. HPV vaccination rates are suboptimal, and missed opportunities for HPV vaccination are common at both well-child care visits and acute and chronic visits. Three groups of barriers contribute to low HPV vaccination rates. The major patient-level barrier is vaccine hesitancy. A key provider or practice barrier is suboptimal communication about the vaccine. And a system-level barrier is lack of feedback to clinicians about their HPV vaccination rates.
We previously conducted 3 sequential randomized clinical trials to test 3 interventions to reduce missed opportunities for HPV vaccination. The 3 interventions involved online communication training, feedback to clinicians about their missed HPV vaccination opportunities, as well as nurse and EHR prompts for HPV vaccination. All 3 individual interventions improved HPV vaccination, vaccine initiation at well-child visits, or subsequent vaccinations at acute or chronic visits. An important question in primary care is whether a bundled multi-component intervention works better than individual interventions. Bundled interventions might address many barriers, but they may also be more difficult to implement. We tested this question for HPV vaccination.
This study used a pre-post design with 24 pediatric practices from pros that had been part of a continuous usual care control group in the prior randomized trials. We're calling them bundled intervention practices. We trained clinicians on a bundled intervention and compared missed HPV vaccination opportunities during a 12-month baseline period when these practices had usual care with a 6-month intervention period following training. As a secondary analysis, we compared missed opportunities for HPV vaccination for these 24 intervention practices versus 48 usual care contemporaneous comparison group practices selected retrospectively. We compared missed opportunities for 4.5 years prior to the bundled intervention, and then 6 months when the bundled intervention practices had the intervention and the comparison practices remained with usual care.
The bundled intervention involved 6 brief online modules. Here is our major result. The main pre-post analysis found that at well-child visits, missed HPV vaccination opportunities decreased or improved for vaccine initiation at well-child visits by 4.8 percentage points and for subsequent vaccinations by 2.2 percentage points. At acute or chronic care visits, there were no significant changes. Here are the results of the secondary analysis comparing the 24 bundled intervention practices in orange with the 48 comparison practices in blue. As shown by the arrow, prior to the start of the 12-month baseline, missed opportunities were virtually identical between the groups. During the 12-month baseline, when both groups had usual care, missed opportunities were higher or worse in the intervention practices. But during the 6-month intervention period, they were lower or better among intervention practices. The difference versus the 12-month baseline was 6.6 percentage points.
This bundled intervention appeared to improve HPV vaccination during well-child care visits. The magnitude of the effect in this bundled intervention was similar to the effect of the single communication training intervention, although this bundled intervention was done after the pandemic when vaccine hesitancy may be higher. Our results support either communication training alone or communication training plus feedback plus prompts, which may add a bit more impact.